his focus is on severe treatment-resistant mental disorders, and he leads several clinical trials. He's also leading the EU Horizon PsyPal project, the project that is investigating psilocybin for existential distress in patients with diseases like COPD, multiple sclerosis, ALS, and Parkinson's. Today, he will be talking to us about the lessons we've learned in clinical trials with ketamine and psilocybin for depression. He will unfortunately not be joining us today in person, but we will be having him on Zoom. So thank you, and give a warm welcome to Professor Dr. Robert Schoevers.
Thank you very much. Good. I think it just turned afternoon. And first of all, I want to apologize for not being able to join you in person, but I will do my best to be there as much as technically possible. In this talk, I will basically walk through the things we have come across as a research team, first working with ketamine and then with psilocybin, and then moving more and more into the realm of classic psychedelics. And I hope this talk will help sketch some of the complexities that you then encounter, and also what kind of questions and challenges we have to resolve if we want to bring these treatments to patients. So that is what I hope you get from this talk. And for that, I will just present some of the experiences that we have had on this path. These are my conflicts of interest, and basically, I think what's important in this field is that most of my research is publicly funded, and definitely my ketamine project. So I do collaborate sometimes with J&J, but none of my ketamine work has been sponsored in any way, and we do research with generic, off-label, cheap as ketamine. Groningen is in the north of the Netherlands. Some of you, especially Morten and Vincent, and probably some others, have been there. And UMCG is a large medical hospital, and we collaborate with a lot of different disciplines also in the wider university. And some of that diversity, I hope you will also encounter in this talk. What got us on this path? It's this. So mental disorders are, of course, highly prevalent. And even though we have quite a number of evidence-based effective treatments, the overall efficacy is just the mean of the efficacy of all of medicine. But still, around 30% of patients across diagnosis do not respond or do not respond sufficiently. So one of the main challenges is to find better cures for the most severely ill patients. And if you look at the field of psychiatry, innovation is not impressive. So this is just one slide from 22 new drugs approved by the EMA, European Medicines Agency, 0 psychiatric medications. And it's either 0 or it's very low. And if it's there, it's often me too drugs. So compounds that not really add something to what we already have. And that is not, well, maybe it could be, but that's because mental disorders are complex. And then, of course, this happened. There is this huge interest. First, I think it started, at least for us, with ketamine, and then with the compounds that form the topic of your conference. We first got interested in ketamine. That's about 2014. And ketamine is an anesthesia drug that is widely used for operations and as a pain medication. It's quite effective for that. And it has now been approved in a lot of countries for intranasal application for TRD, treatment-resistant depression. Its working mechanism is very different from other antidepressants. It's mainly through the glutamate system, and then downstream it affects neuroplasticity, immune systems, and a whole range of other downstream pathways that again may touch upon serotonin, noradrenaline, so the more usual neurotransmitters involved in, for example, antidepressants. I'm not going into all the details of that, but it is really something new in this field. We reviewed the evidence at that point, and we found that, and we got interested in the oral formulation because we thought, well, IV is maybe a bit complicated if you want to scale it. We never thought about intranasal, and we mixed the injection fluid into a sugar drink. So then we made oral as ketamine. And the literature at that point suggested that that might be effective, but it was still very patchy at that point. So that is what we did in our first pilot study. So what you then do is you make a treatment protocol. You go to the METC, the Medical Ethical Commission, and you say, well, this is a drug that is already, that I as a doctor can prescribe. I can prescribe it to for a patient with another indication if this patient has had everything the field has to offer. So all the the different antidepressants, psychotherapies, often also electroconvulsive therapy, and there's no credible other option. So that's what we started with, and we went to the METC because we also wanted to publish and we wanted patient-informed consent. Morten is now going to start a small video fragment from one of the patients in this early program, and what she was on television because she wanted to tell the world about her experiences. And what you see first is she tells something about her background and about the depth of her suffering, and then you see a little bit of how she improved. And Morten, I think you can stop the video. I'm not sure if I will be able to see it, but at the end, when she sorry? Okay, great. So let's go and see if it works.
Gewoon zo op, klaar, uitgevochten, uitgestreden.
En waar strijd je dan tegen?
Tegen de ziekte. Ik vind depressie is een ziekte, is een hersenziekte, zeggen ze nu tegenwoordig. En dat is het ook echt. En in ieder geval, in mijn geval, omdat het gewoon echt erfelijk is. En het maar terug blijft komen en zwaarder wordt en dieper wordt. En ik eigenlijk gewoon steeds gehandicapter word. En niet meer in staat ben om mijn eigen leven te leven, om voor mezelf te zorgen. Om te zijn wie ik ben, om mijn passies te voelen.
Eva Bouwman is 39 jaar. Ik ontmoet Eva begin dit jaar. Ze woont dan bij haar ouders in Den Bosch. Als kind was Eva al depressief. Als ze 15 is, doet ze haar eerste zelfmoordpoging. Waar zit die oorzaak dan volgens jou?
Volgens mij is het chemisch. En dat is ook wel het frustrerende, omdat alles wat ik doe eigenlijk niet werkt om de depressies tegen te houden, te stoppen, af te laten nemen.
Wat voor behandelingen heb je gehad? Kan je daar een overzicht van geven?
Ja, ik heb heel veel psychotherapie gehad, gedragstherapie heb ik gehad. Ik ben in het alternatieve circuit, heb ik alles gedaan wat er mogelijk was. Heb alle vormen van medicatie gehad. Ik heb 40 ECT's gehad, elektroshockbehandelingen.
Dat hielp niet?
Dat hielp een paar dagen. Dus daarom heb ik er zoveel gehad. Ik ben eigenlijk heel mijn leven voortdurend bezig om niet ziek te worden. Het geeft ook hoop, want ik kan en wil niet meer met deze depressies verder leven. En ik heb met mijn familie en met mijn arts afgesproken dat ik tot mijn verjaardag geef om te kijken of dat ik nog een oplossing vind. En anders stop ik met leven. En dit is een van de oplossingen waarvan ik gewoon heel veel hoop krijg.
10. Tot je verjaardag.
Ja.
Dat maakt het wel heel erg spannend, hè?
Ja, dat was het ook. Dat is het ook.
Vanwege maart als ik Eva Bouwman opnieuw ontmoet bij het Universitair Medisch Centrum in Groningen. Hey Eva. Hi. Hey. Nou, voor de behandeling.
Ja,
jij hebt het wel vaker gedaan. Wat ga je nou straks krijgen? Hoe gaat dat in zijn werk?
Ik krijg straks ketamine. En dat krijg ik in een bekertje. Dat drink ik dan op.
Ja.
En dan eigenlijk kun je er de klok op gelijk zetten. Dan na een kwartier raak ik wat onder invloed.
Ja.
En dan na 3 kwartier begint
dat weer een beetje
bij de mensen te komen.
Ja.
En ben ik weer redelijk aanspreekbaar. Ik kan daarvoor ook wel spreken, maar dan ben ik een beetje... Ja, ik vergelijk het altijd met dronken.
Ja. Je hebt het nu al een aantal keer gehad. Heb je het idee dat het werkt?
Ja, enorm. Tenminste, als ik ook van mijn familie hoor. Mijn ouders die waren er de eerste keren bij. En toen ik de eerste keren de ketamine kreeg, was ik wat grauwig. En mijn ouders vertelden van, goh, je krijgt in één keer je kleur op je gezicht. Ja. En je ogen staan weer sprekender. En dat was gewoon na één inname.
Wat zagen zij eigenlijk wat tegen? Oké, dus hier gaat wat gebeuren.
Ja, hier krijg ik mijn ketamine. Ik heb de eerste week van de studie ook hier op zo'n kamer gezeten.
Ja.
Thanks a lot. Well, I think this gives an impression of the changes that may occur if somebody has a beneficial reaction to ketamine, but that is only the start. Let me see. So we then designed a clinical trial where we compared oral esketamine to placebo in a double-blind randomized study, and we used the same dose that we used in our pilot, which was low dose every day, 6 weeks consecutive. The good thing about this study was that it was totally blinded. Patients were not able to guess in what condition they were in. And as you may well be aware, this is a major issue in this whole field, because it's very hard to blind something with a strong immediate subjective effect. However, we also found that it was totally ineffective. So the placebo did just as well as the ketamine. And that, of course, did not make us very happy. Luckily, we had an open label second phase of the study, and we had promised patients that if you participate, we will allow you to try esketamine in a different regimen in an open label next phase. And then, surprisingly, we did see a relatively good signal. So we saw that nearly 50% had a minimally clinically important difference, which is sort of the low end of what you clinically would call a relevant improvement. and about a quarter had a response, and 15% had a remission. And you may think that that is not very impressive, but in this group, it's 2 or 3 times better than other treatment options. So it is a strong signal. But the downside is that it wasn't blinded. So it doesn't prove really that ketamine works when you compare it to placebo. But the regimen was different. The dose was really different. So we still think that that was sufficient evidence to go on trying this and studying this. One of the things we were concerned about is whether if you give such a medication for a longer time, whether it might have negative effects. We know it affects urinary tract, especially in heavy users. We did a review in which we found that also in mostly heavy drug users, it affected the gray matter volume, so it really affected cognitive functioning, which of course is worrisome. And then together with an Australian group, we participated in developing a side effect tool because it wasn't there. We had to make this from our own findings, from assessments of side effects, so more broader lists that we made, but you have to have something that you can use for every patient in every session. So it doesn't have to have 30 items because that's not clinically feasible. So we try to develop a side effect tool that is manageable and that has the main topics. Another issue that we came across, and all of these things are also relevant for classical psychedelics, is can we combine ketamine with other medications? Because many patients with treatment-resistant mental disorder are on some form of medication, for example, antidepressants. Usually we would want to keep them on antidepressants if they improve, because it may be helpful for relapse prevention. But can you then combine? So we are relatively happy with ketamine in terms of possible interactions with antidepressants, and even with male inhibitors, which is a bit more risky. We did a few pilot treatments, and we also looked at the literature, and we now sort of developed a way in specific cases to do this in a responsible way with a lot of checks and balances. Another important issue, because if you treat patients with severe depression, they may have psychotic depression. And it's even likely in treatment-resistant depressions. So, but ketamine was used earlier as a psychosis inducer. It may make you psychotic. So should you then not use it in the patients who may need it most? And again, we found that the literature, and this is all individual cases, is not that worried about it, because that the real explanation is hard to find. But we feel that in psychotic depression, the depressive delusions are more sort of a more severe form of depressive thought than what you would call a schizophrenic psychosis. But that's not really proven. But we thought it was relevant, and now we are a bit more open to treat also these patients if we have no other options. Another aspect, one of the researchers in my group is a philosopher, and he is very interested in qualitative research. His name is Joost Breeksema. Many of you may know him because he's also the organizer of the ICPR conferences. And what he did in his PhD project was interview the patients whom we had treated in our esketamine oral treatment program. And he wasn't involved with them before, and he just openly asked them about their experiences. And you have to take into account that we have very nice treatment teams, nurses who take good care of people, and we are really trying to do as good as we can, but we treated ketamine as an antidepressant. And we said, well, yes, you may have some dissociation, but don't worry, the nurse will come and take your blood pressure, just relax, and after 30 minutes, you'll be back again, etc. However, the patients told us when we really asked them that many of them had been struggling to maintain control rather than let go. And for many of them, for several of them, this had been quite scary. And you have to realize that patients with severe mental disorder often, substantially more often than others, have traumatic early life experiences, may not feel safe in letting go control. So we felt that we hadn't really prepared them for it as you should. And also, we have asked them about what did you think about, what content, what in your memory did you come across in these sessions? Because these are repeated sessions twice a week for at least 6 weeks, and also we do it longer. And patients reported, and it sounds a bit dumb, and I also think it is a bit dumb that we didn't prepare for this as we possibly should have. But patients told us that quite a number of them went through a psychological process. So they encountered a lot of topics that were relevant to them, and that, from a psychotherapeutic perspective, are really very nice to work with, very relevant. And these people were in treatment, and some of it was discussed, but we didn't systematically plan for it. And we didn't have really a good model to use those experiences in subsequent treatment sessions. And then we looked at the literature. So what should you do when you do psychotherapy with ketamine? And as you may know, if you look at the literature, you could roughly say that over the tens of years, everything that psychiatry and psychology has been interested in terms of psychotherapeutic directions has been used together with ketamine. So it's hard to say which one is better. That is always hard to say with psychotherapies, with or without these compounds. But it's very heterogeneous, and there is not one approach. What do you do then? We developed a ketamine support module in which we have much more attention to preparation, to support during the sessions, and also to integration. And we used some of the things that we learned from the psilocybin project that I'll talk about later a bit. And we are now writing that down and also formally evaluating in what way it contributes to the overall outcome. I was really surprised because I think I and my colleagues are really open to both the psychological and the biological aspects of mental disorder and of people in general. But if we hadn't done this if we hadn't assessed this in a systematic way, it might have taken quite a bit longer before we use this in this way. And if you look at the whole ketamine field, this is not what people usually do. This is also not what ketamine has been registered for. In the meanwhile, J&J developed Spravato, so intranasal, which was also proven effective, and there's quite a number of studies. But at least one downside is that the cost is really impressive, especially if you compare it to the cost of generic preparation that we are studying. And we hope that in our studies, a next step will be formal registration, depending on a number of studies that are currently running. And a last aspect that is really relevant to patients, and all of this also is relevant for classic psychedelics, is, okay, if people improve, does it cure? And likely it doesn't, because severe mental disorders are combined with chronic vulnerability. But you hope that you can really improve somebody's prognosis, that not 1 week after response or remission, people relapse into severe depression, because then you sort of lift somebody up, and then the fall may be even more harsh. But there's not so many studies in the literature that have looked at this, even though clinically and also societally it's hugely important. So what we did is a systematic review, and from the literature, which you can see from the table, don't read it, but just look at all the voids and the numbers. There is really patchy evidence. So in our next projects, one of the main research questions that we try to address is, what do we need to do to keep people out of depression, and not for a week, but at least a year. And in more naturalistic studies, we are now assessing maintenance treatment and also tapering. So step by step reducing ketamine treatment and seeing whether somebody is able to develop other strategies to not become depressed again. So where are we now? We do a nationwide clinical study in which we compare ketamine efficacy to electroconvulsive therapy, which is sort of the most effective treatment that we have in psychiatry. And apart from efficacy in the first 8 weeks, we also have this 12 months maintenance phase. And it's a non-inferiority trial. And if we can show that ketamine is non-inferior, then the Netherlands Care Institute will try and help us with a registration file for generic production. And in the international literature, and in the meanwhile, studies do appear that suggest that ketamine is non-inferior. This is an American study that came out last year. So we are hopeful, but we have been surprised more often. And we now have a number of other pilot studies where we use the same support module plus the oral esketamine in bipolar depression, which is an under-researched form of depression, in especially anorexia, in obsessive-compulsive disorder, and also in end-of-life distress. So in patients in palliative care who develop psychological problems facing end of life. And we have another study, just a brief example, where we are also studying racemic ketamine versus benzodiazepine for acute suicidality, because that's also an indication from the literature that seems to be promising. I have no conclusions on that, but we will in the near future. So then we move to psilocybin. Our journey with psilocybin started with the COMPASS trial, where we were one of the sites. And that was really interesting because our therapists got trained and we all got more of an idea of the effects of this treatment and what you should do to guide people through a session. This study, it was published in the New England, showed efficacy, showed a positive outcome for the 25 milligram dose. So this is really promising for our field. Some people say that the total response and remission rates were not that sky high, but I think comparatively it really showed efficacy, and I think this is really encouraging for further projects. Also in this study, we took the liberty of interviewing patients after the trial phase, and that also taught us a lot. So, who were these patients? They had been in treatment often for a long time. They had problems in trusting mental health care professionals. They hadn't had very good outcomes. They had, and for them, the approach of the study therapists was crucially important, and they valued. We were happy to hear that they valued that very much. Also, these patients had trouble in letting go, in surrendering, and also these were all psychedelic naive patients. It's really an important distinction, and they were definitely not always positively surprised by the overwhelming experience. And they told us that it would have been better if we had been more prepared, or maybe if we had started at a lower dose. And also, a number of them told us this is qualitative research, so the numbers really don't mean anything, but they expressed a need for more sessions because the process wasn't ready when the trial stopped. So these were also important lessons that we took with us for our next projects. We also looked at adverse effects, because there is this claim that psychedelics don't do any harm, and this would be great. But we found that the literature that is usually quoted for this is not 200% reliable, because many studies, and especially the older studies, have only mentioned adverse effects when they were spontaneously reported by patients and then noted down by the therapist, and then were noted also in the results of the trial. So that is a number of hurdles. So a definite thing to do for the whole field is systematically measure all of these potentially adverse events or adverse effects. They can be mild or not so mild across every psychedelic study that the field undertakes. And this is now happening, but I'm not totally sure that the literature from past years or tens of years is fully credible in this. The other thing is, of course, what is a challenging experience in a psychedelic session? You could say if it isn't challenging, maybe it doesn't work, and it can still be therapeutically meaningful. But we are sure that this was not always the case in everybody. Another question, not something that we specifically looked at, but I think that you should take into account, is that the patients that did participate in psychedelic trials are still a selection of people who self-selected, who were interested, who sometimes had prior experience, and who are not totally representative of the most severely ill patients with mental disorders. I will not, for the sake of time, cover this one. And then some future directions that we took from this experience. As your introducer told, we are now setting up the psilocybin therapy for psychological distress in palliative care patients. We do that with 4 clinical sites in 4 EU countries in patients with severe medical illness. And being mindful of the earlier lessons, we have 2 dosing sessions with increasing dose and also with more psychotherapy sessions around it, so that we both help people sort of get used to the experience and try to make most of this treatment. There is a tension because these people are medically ill and are not high on energy, and this is a challenge in terms of the number of sessions and the number of contacts. But we need to see how this works. So we do ascending dose, and some of the things you've seen earlier come back. So we are now writing a review on combinations with other medications. So we do not taper them from frequently used antidepressants. We can look at the effects in different chronic medical conditions. We assess maintenance for 6 months, but then we also go on. So we have continued care after the first phase of the trial to see if the response can be maintained over time. We have a standardized therapy, and people are trained and certified, and there is regular supervision during sessions. And there's also an ethical work package, because I will talk a little bit about ethical aspect after this. So we think there's a lot to be learned from this study, and it's great that we are able to do it. And it's also we're very happy that the EU Horizon program is now funding this type of research. NDMA, we didn't do NDMA studies ourselves, but a number of things have affected how we look at the NDMA field. I don't want to spend too much time on this, but there have been cases also in the MAPS trial, and this one, unfortunately, is a well-known case of a patient who was treated by a therapist couple, and she also stayed at their house and then developed a sexual relationship with the male therapist. And this MAPS, which is to some extent understandable, had problems adequately dealing with this. And of course, they were very unhappy with it. But this sort of loomed over this whole study until today, I would say. And it's not a totally isolated case. More cases are appearing in media. In London, a well-known psychiatrist, psychotherapist has lost his license, at least for a certain period of time. And there's quite a number of other mentions of these kind of events in psychedelic therapies. And I think we should be aware of that. We're now writing a paper on, do we know how often this occurs and what should we do to prevent it? I think we should be mindful of the fact that the altered state of consciousness make people very vulnerable and open and dependent on therapists. And this plays a large responsibility on everybody who uses these compounds. And I think in Switzerland you will definitely agree, this can only be done by professionals if patients are treated who are also can be held responsible against professional standards and regulations. And then you can talk about informed consent, non-touch policies, supervision, etc. And I think this is really important in the field. And one of my heroes in psychiatry is Professor Glenn Gabbard. And when I was a young resident, we already had his teachings about all of us are potentially vulnerable to boundary transgressions, not as serious as the one I just showed, but it is something you should be mindful of, and you should learn how to work with transference and countertransference. You should organize regular supervision, and you should not do these things in isolated practices, and also not in a situation where you think you are the only one who can really do it. It's dangerous. Some of this loomed over the FDA, but the FDA, so the American authority that regulates the introduction of new medications for patients in the US, and you're probably aware of that. So they rejected the advisory panel, very clearly rejected the case presented by Lykos. They were worried about unblinding. I talked a bit about blinding and unblinding and the bias that could be introduced to that. They were worried about the fact that the psychotherapy was not very clearly described. I think it was in this trial, but they didn't know what to make of it and how much of it. And what you basically try to register is a pill plus therapy, and FDA and also EMA has a lot of trouble in dealing with that. The durability of effects, so there were really a whole range of things that they problematized, and that I think as a field we need to take into account if we want to move this forward. And this is Michiel van Elk was one of the speakers yesterday. He, I think he will have told you some of that, but if you look critically at the literature on psychedelics, there is room for improvement. And I think we as psychedelic researchers should be the ones who try to solve it. In the Netherlands, we are looking with a lot of interest to the situation in your country, where you can use psychedelics in treatments under a number of rules. We are definitely not that far. In the Netherlands, it can only be done in clinical trials, but we had an influential committee recently advising about psychedelics. The focus was MDMA, and they addressed both the potential harm and also the fact that the Netherlands is a major producer of MDMA in the unofficial field. So we have Mexican cooks that are very active in a host of locations, and that is a big criminal business. So they did not propose to shift it from list 1 to list 2. And there's also Dutch cooks, by the way. However, there is a medical need. There is a promise that it's effective, and they suggest that we do a naturalistic trial, like the Australians, for example, have suggested and are doing, although there are also differences. So this is sort of our walk through this field. How would we then go further? We wrote, so the Dutch government, we were happy to be able to influence a little bit the government stance on this. We wrote a report that we offered to the Minister of Healthcare, and we laid out a call for a national research program where we hope to be able to do larger clinical trials where we can address safety, efficacy, cost effectiveness, the amount of therapy needed. And also, one thing I didn't talk about is we also would like to study the transdiagnostic mechanisms that may be affected by psychedelics, because psychedelics appear to work for different disorders with different compounds. and what does that mean on what they really target. And of course, in the field, the idea that psychopathology has a number of trans-diagnostic aspects is something we all know, but psychedelics may also help us really get our fingers behind these mechanisms. So what we're now building. Yes, I have 1 or 2 minutes and then I'm finished. So we are now building such a network in the Netherlands with all of the academic psychiatry centers, together with a range of specialized centers, and we are now preparing a national clinical trial with MDMA, probably for PTSD. And we hope to work that out during the next year, and then do our best to support this development by research that I hope is valid and trustworthy. And of course, we also do this with our European colleagues, some of the organizations you see here, and I'm really happy about these international collaborations. So thank you for your attention. I'm looking forward to questions, and let's see how that works.
Great. Thank you so much. So we're going to have questions. Vincent is going to go around with his phone just so Dr. Schoevers can see who's talking, so don't be surprised.
No, it works fine. I can see Vincent, and I probably can hear what people are saying in his phone.
Please speak
Vincent,
quite close to the mic because so he can hear properly.
Okay. Yeah, Vincent, your mic is still off.
Hi, can you hear me?
Yes.
Okay. Thank you very much for your presentation. I've been following the PsyPal project with great interest. What I wanted to ask, though, is what do you think about some people in the space hold the position that psychedelic therapy is not disease modifying, and as such basically not valid in a way. That is a simplification, of course, but I was hoping to get your perspective on that. Thank you.
Thank you. It's a great question. Antipsychotics, I would say, are disease-specific because they treat specific symptoms, and they do that in an effective, credible way. Antidepressants affect mood, but with mood you can look differently at the problems you're facing, and there's always an interaction between your personal history, the things you have encountered, the things you struggle with in your life, and something objective that we call depression. And in that sense, I do not really think that psychedelics are that different from something we call antidepressants. Antidepressants are used all over the board for many different disorders, even though we call them antidepressants. So I think if you zoom into it, many of our treatment, and we do psychotherapy as proven effective treatment for a whole range of mental disorders. And psychotherapy only works if you tailor it to the individual. So you could say that psychotherapy in every patient is a bit different. And then does that mean that it's disease specific, or is it not disease specific? So I think it's really interesting to speculate about that, but I'm not impressed by the argument that psychedelics would not count because they are not enough disease specific. I think if you look critically at all of the rest that we do, you can have those kind of questions with some differences. ADHD medication or antipsychotics may be more close to something which is a core element than other treatments in psychiatry.
Can you quit the screen sharing?
Yes, sorry.
So thank you for your presentation. I wanted to ask, because you told about this misconduct from therapists during the sessions, and on the other hand, on the clip you showed, the woman told that her parents were present during taking ketamine. So what is your experience with having friends or relatives during the treatment sessions? I think it's a complex interaction that can arise from that.
I think so. With ketamine, we now have people who are in a national program, 200 something, who are on maintenance ketamine. So they have once every 2 weeks or once a month or once per week, and we taper, and they take it at home. So we prepare that we start in the clinic, and we help them develop an approach, and that we do with therapists. And then, but some patients always have a family member present, and then when they move it to their homes, they develop their own ways to do it. So yes, I'm really in favor of involving significant others if the patient feels comfortable with that, of course. If you have treatments that are once or twice, such as psilocybin or other psychedelics, or so a limited number of sessions, I think, but I think you would have in Switzerland, you would have more experience with that. I would be a bit more hesitant because we all know that to be a guide, you really have to know what you do, what you should do, and even more what you shouldn't do. So if the relative gets as overwhelmed as the patient and panics, that is really bad news. I would not be totally in favor. And I think the main message from these incidents should be perhaps not that they occur, because they occur all over mental health care, and they have occurred all over mental health care as long as the field exists, unfortunately. But I think the field has also been a bit naive about this aspect, and I think that is really dangerous, because it is not for nothing that we are trained to be aware of all the interpersonal dynamics that occur in the contact with a patient. And I think people in the psychedelic field are sometimes blatantly naive about these aspects. And I think as a field, we should be worried about that, because you don't need too many incidents to kill such a development.
Can you hear me? Yes. So I also wanted to thank you for your engaging talk, which was really nice. And I wondered, at some point you mentioned that there is like an aspiration in order to make more standardization within the way of how we're approaching therapies. And that made me reflect, because yesterday there was a speaker telling that also the efficiency of the therapy also depends on whether the worldviews of the therapists and the patients they are matching. So that it's actually better when they have like the same paradigms about the world or same assumptions about the world, that it can be actually more efficient training. And I was wondering, because that just seemed to me a bit contradictory to this aim to have more standardization. And I was wondering, like, how can we make sure that we step into our ability to question this standardization, or how can we also be testing on whether this standardization is good? Or also just like acknowledging that there have been people working for so long, like in indigenous cultures, with different forms of therapies, and how can we make sure to just also see that there can be other forms of training as well in order to hold space for psychedelic experiences. So I was wondering whether there have been any studies being done on that, or what your personal reflections are on that. Thank you very much.
Thank you. Yeah, that's another great and very important question. If you look at the whole field, there in the literature, both on classic psychedelics and ketamine, it has not been very standardized, but the larger and the more dominant projects, especially recently, have adopted more formal guidelines and trainings, and I think all of that is really important. So I think we should have a basic training and a basic frame in order to adapt, to work with because what you do in every kind of psychotherapy is you have a shared narrative of what are the problems of a patient. Then you have a shared idea about how we are going to work with this, whether it's CBT or interpersonal or psychoanalytic. And what we know from psychotherapy research is that what counts most is whether you have some kind of shared understanding of what is the problem, how are we going to work with this problem, and is this really at the core of what I suffer from, and do I trust this therapist? So all of this is totally unspecific. So there really you have a very good point. We don't know. On the other hand, and if you look at the whole psychotherapy literature, I don't know if you're familiar with papers that describe the dodo verdict in psychotherapy. So all must win and everybody must have prizes, because we cannot prove that one psychotherapy for a condition, if it's adequately structured, etc., is more effective than another. Are we going to find something like that for psychedelic therapies? It will be hard, but I think we should try to agree on the importance of preparation, session support, integration, and then I think we should do studies, for example, looking at how much of that would people need. You might do comparative studies with people who use a different reference frame, but is that really going to solve it? I'm not sure, because a good therapist, regardless of the reference, will try to be close to what the patient experiences, so that how the patient views his or her world. So if you're a good therapist, you don't only stick to your method, but you're also moving towards the vision of the patient. So it's another subject that we can talk about for a long time, but I think we need to explain to regulators and to people who are looking at this field what we know and what we don't know, and what the main knowledge gaps are, and look at whether we can address them in smart studies. But I think it's unlikely that in psychedelic treatments we will have the final answer on what psychotherapy is best. So I agree with you, but on the other hand, I think we can do a bit better than we do now. And if you look at the pharma side, there's a big debate now. There's pharmaceutical companies that say it's all very nice, psychotherapy, and it could probably be very relevant. But if we want to register it and we overload our registration studies with a whole bunch of psychotherapy sessions, it's never going to work. So it's better to try and get it approved in a less psychotherapy dense form, and then develop guidelines based on studies on whether it's better to have more sessions, something like that. But the field is totally not in agreement on this. And that hampers progression.
Great.
I'm sorry, I cannot solve it. I would like to.
Great. Time is up. Thank you very much, Dr. Schoevers. Please stay for 1 second, and then we'll give a round of applause.